Okay, so good evening, everyone, and welcome to EMED 2025. And just to give you a little bit of what EMED is and what we're going to do today. So EMED is an annual update on the papers which are potential to change our clinical practice. So we're going to do this in four parts. The first part today is on endocrinology, core endocrine, without involvement of any diabetes. So we'll be discussing about osteoporosis, thyroid, parathyroid, and so on. And in the second part, unfortunately, the second part, which is there to be there on 22nd, this Saturday, is to be rescheduled. So we'll let you know. That was to be on cardiology, but unfortunately, for some reasons, we were not able to have that. And after that, we are going to have a topic on core diabetes. And finally, we'll have the last session on obesity. So these are our four sessions that we are going to have on EMED. And we'll be focusing on research papers that were published in 2025 and which have potential to change our clinical practice. So just some housekeeping rules. So this is the Zoom webinar platform. And on this platform, you will be able to ask your questions in the Q&A section. So if you have a question which is relevant to the discussion that we are having, you can put it up on the Q&A and we'll be happy to take it during the discussion itself. But if you have a question which you want to ask in person, then please, wait till the end and we'll have a few minutes for our discussion in detail. We'll allow you to unmute yourself and ask those questions. So EMED 2025 is proudly sponsored by Lupin Ezadio. There have been, again, just to reiterate, there has been no editorial influence of the company. This is a complete editorial freedom that we have. So whatever content that you're going to see will be totally free from any kind of editorial interference. It's a pure academic exercise, which does not involve any pharma promotion at all, right? So that's the disclaimer. And last time we had, very good reactions to the entire thing. This went very well. So this year, again, hopefully, we will live up to the expectations of that. If you're missing anything, if you missed the session, please feel free to join us on our channel, which is Endocrinology India. And we'll also have all the research papers, which we are going to discuss, the summaries of these, our video, which we are going to record today, and the presentation. Everything will be available to you on our platform called technochronology.com. We'll be sending the link to your email. So after this end of the session, you'll receive an email with the link. Also, I'm putting up the link in the chat as well. So if you're able to access the chat, you will be able to see the link and join us for that. Okay. Archit, can you send the guest link to Mr. Subhash? You send it to me. So if you can send it to
Sir,
Mr.
I have
Subhash.
also forwarded it to him,
To him.
Dr.
Okay.
Suhas, sir.
Yes, yes. Okay.
Got
Thank
it,
you.
sir. Got it.
Thank you. Okay. Right. So I just put a link in the chat, and this is a link to our technochronology forum. So if you miss anything, if you feel that you want to go back and have a relook at it, all the papers that we're going to present and all the slides and everything will be there on the platform. So we'll be happy to you can have a look at this. So without much ado, let's begin our session today. And it's an absolute privilege to have a young and dynamic endocrinologist with me today, Dr. Soumita Mandal. Dr. Soumita has done a MD in general medicine and DM in endocrinology from the prestigious IPGMA, Kolkata. She's currently she's an academic, and she's an assistant professor at the Department of Endocrinology at NRS Medical College and a hospital at Kolkata, which also runs an endocrinology DM program. She's also consultant endocrinologist at Narayan Pruthalaya in Kolkata. She's a proud member of Endocrine Society of India, Endocrine Society of Bengal, RSSDI, and the AACE. And she has published many articles. You can just check out a Google Scholar profile and wonderful articles. Like I said, she's an academician, she's a researcher, and some of the areas of interest for her are diabetes, pituitary, and reproductive endocrinology. So Soumita, welcome to this session, and thank you for joining today for this.
Thank you, Dr. Om, for your kind introduction, and thank you, Lupin.
and it's my honor to be a part of this YEARMED program. This seems really interesting for me. I'm really looking forward to this. So I hope we'll be having an interesting session in the next few minutes.
Thank you, Dr. Soumita. So, yeah. Okay, so today we are going to take 4 papers. We are going to discuss a very important and practice-changing update on osteoporosis. We'll discuss something very interesting which was published in Indian Journal of Endocrinology and Metabolism. And this year, we have chosen papers from India because most of us, since most of the audience is going to be from India, we are looking at papers which are relevant to our practice, and we'll be taking, so out of the 4 papers, we are proud to have 3 papers from Indian Journal of Endocrinology and Metabolism. So we are going to discuss about a novel intraoperative procedure for recognizing parathyroid tissue. We'll be discussing a very important paper, which then Dr. Soumita tells me that she was actually a judge for one of the, for this paper, and this paper actually won the first prize. So it's a very interesting paper and very important clinical issue that we are going to discuss. And then finally, we'll discuss something something we face very commonly, uh, a raised TSH, which is actually not something what it should be. So these are what we're going to discuss in today's 4 papers, which are all going to perhaps influence your practice in the upcoming year. Okay, so let's begin with this. So this is fracture prevention with infrequent Zoledronate. So this is based on a paper which was published in New England Journal of Medicine, the sort of the most premium journal for medicine per se. So let me then discuss about what is really happening today, right? And Dr. Soumita, what's the usual approach that you have for any postmenopausal women in terms of fracture prevention and osteoporosis management? So what's your
Currently,
usual
what
practice?
we have been, uh, I guess I'm audible correctly,
Yeah, yes, you're
and
perfectly
my
audible, Dr.
voice is
Soumita.
not breaking, right?
Yeah, you're perfectly audible, Dr. Soumita.
Okay. So currently, what we have been following till now is sort of a reactive approach. That means whenever a woman or a man comes to us with history of fragility fracture or with a frax very high score or like a VMD with a very significant bone loss, that means the T score is less than equal to 2 point minus 2.5, then only we start treatment or go for the interventions. So again, I would say that this is a reactive approach. We do not actually preventing or the first fracture or not going for the primary prevention of the disease. We are going for the secondary prevention. Currently, what we have.
Absolutely. Absolutely. So what we have is very rightly said, a sort of a laissez-faire, slow, preventive, sort of a reactive kind of approach where once the patient comes with the fragility fracture, that is when we move into action and start taking some steps. So I think the ideal way is to have a primary prevention where you can actually prevent the first fracture from happening. And if you could probably take a step back, make it more proactive and more instead of reactive. So that's the whole idea. Again, as a rule, as a general practice, currently the guidelines recommend that we should screen women more than 65 years. So even amongst the proactive and the kind of primary prevention, there is a little bit of a lag, and I'll come to that. So what happens is that as of right now, the current guidelines recommend that any women above 65, we should screen them for osteoporosis. So you do a DEXA scan and a FRAX score for women more than 65 years of age. And in such patients, if they are found to have osteoporosis, then they are started on a relevant treatment. Now, there are certain issues with that. Dr. Soumita, what do you think about this usual standard of care approach, which is there? Do you think it is we miss out a lot of women in this way by this process?
Yes, because we rely on BMT solely.
Right.
And the current guidelines sometimes rely on FRAX and sometimes on BMD only, but
Mm.
there are certain factors which determine the risk of fractures which are independent of BMD. So
Correct.
in those cases, I feel we are missing out those patients who are having probably low normal or normal BMD, but still
Mm.
have a high risk of fracture because of their age, BMI, risk of falls, frailty, and many other those which are not captured in the fracs or not
Mm.
even captured in the PMD. So yes.
Absolutely. Absolutely, Dr. Soumita. And one thing, I still remember giving a talk to a group of gynecologists about the guidelines on osteoporosis in postmenopausal women. And this is maybe 5, 10 years back. And there's one senior gynecologist who stood up and said that we're doing it all wrong. I said, why? He said, the maximum bone loss occurs immediately post menopause, right? So when a woman, just had a menopause, that if you see again, you see data, there's a ton of data. The maximum kind of bone loss happens at that point of time. So if you had a time to intervene, that is the right time to intervene, right? Instead of waiting for typically an average age for menopause is 50 years internationally. In India it's in fact 45, right? So or 46. So you are then you're waiting till 65. That is about close to 20 years
Yes.
after the menopause, right? That's when you're
Current,
screening.
yes,
Yeah,
because I feel that is why the current NOJJ, that is UK guidelines, recommend all postmenopausal women should be
correct,
screened for osteoporosis. They
correct,
have
correct, right?
currently changed their outlook, and they have come with a new recommendations that all postmenopausal, they do not want to wait till the age of 65 or like
Correct,
more.
correct. Yeah, absolutely, right. So that's the challenge that we have. So that's the dichotomy we have. The other side of the problem, Dr. Soumita, is that we don't have enough data for treating women. I think it's just data which is emerging. Most of the data then comes from women above the age of 65. So all the fracture prevention data, a lot of it is dependent on those women, and that's why there's probably a need for the more proactive and more research in that women between the ages of 45 to 65, right? So what could we do for these women, right? So that's where we are kind of having a problem, and because we don't have enough data to see whether treating slightly younger women could really be helpful. And additionally, there's one more issue. We do not have much data in terms of women with osteopenia. So we know that women with osteoporosis, obviously we're going to treat them. But what about the women who have a T-score between -1 to -2.5? Unfortunately, we don't have enough data for these women, right? So that's another challenge, which we have. So that is where it brings me to the paper. I think this is a very important paper, and I think this is what will eventually change our practice, I'm sure, because it's not only it's a very well done study, but it's a study which was published in New England Journal of Medicine. And when you have an important research paper published there, I think there is definitely, it does impact the guidelines, upcoming guidelines on the topic as well. So this is the paper. It's called Fracture Prevention with Infrequent Zoledronate in Women Between Ages of 50 to 60 Years, which was published in New England Journal of Medicine in 2025. And Dr. Samita, you had gone through this paper. So I'll just quickly go through the methodology of this, what they did, and then we'll discuss this in more detail. So they took about 1,000 women between ages of 50 to 60 with osteopenia and not osteoporosis. So that's another interesting area which they looked at. So they took women between T-scores of -1 to -2.5, and then divided into three groups. So the first group, they gave zoledronate initially, and then every 5 years, they kept giving them zoledronate. So instead of giving it again, zoledronate, typically postmenopausal women with osteoporosis, we give them every year. But here they gave one dose of it, and then they waited for another 5 years and gave a second dose after 5 years, and so on. The second group, what they did, they gave zoledronate right at baseline, and then after 5 years, they gave placebo. And the third group was just given placebo. So that is what they did, right? And they did a 10-year follow-up of these women, and they are looking at new morphometric vertebral fractures. So it's a prospective study, again, very well conducted in that sense. So the idea was basically they are looking at younger women who have milder disease because they have osteopenia, and they are then looking at infrequent dosing. So they are completely changing the strategy in terms of what we usually do, right? So this is the trial. So Dr. Samita, what do you think about this trial design? Do you feel that this is uh, uh, a well conducted study? This is a good idea. This is what should have been done, or do you have any kind of critique on the methodology as well?
Um, uh, yes, I would say it's a very interesting one because
Yeah.
till now we had small scale data on patients with osteopenia. who had been has been benefited with zoledronate given every 18 months.
Right.
Not
Correct.
more, not more than
Right.
that. But here they have applied the frequency like 5 years apart. So it introduces a very relevant questions whether it is going to be useful or not when given in such a broader interval. So this is number one. Number two, the patients to start with had mild osteopenia. Even some of them had normal BMT. So whether they are going to benefit at all, this is also a relevant question. So let's see what did they find in the next slide.
Yeah, exactly. So very interesting considerations. So again, just to reiterate, they took women between ages of 50 to 60. And just to inform to the audience that a T-score is what, when you compare the BMD of these women with somebody who is a young woman of, of similar race. And if the BMD score is less than minus 2.5, or a T-score is less than minus 2.5, then you define it as osteoporosis. If it's between -1 to -2.5, then it's defined as osteopenia. So that is what we did. They excluded women with osteoporosis. So they do not include with any women with osteoporosis were excluded in the study. They were randomized, as we saw, to either zoledronate or zoledronate followed by zoledronate or zoledronate followed by placebo or zoledronate or placebo followed by placebo. So that was the three groups. And they gave 2 infusions over 10 years. So at 5 years, and then, so that was the whole idea. So that was the approach to the entire trial. Okay, now this is where the results are, right? So this is again an interesting result. So the zoledronate to zoledronate group. So those women who you received zoledronate every 5 years, 6.3% developed vertebral fractures, and then compare that with the other extreme where women were just given placebo, 11% developed vertebral fractures, right? So there's a clear difference, and the relative risk is 0.56 with a confidence interval of 0.34 to 0.92, which means that it's statistically significant. And the number needed to treat was 21 to prevent one vertebral fracture over 10 years. Okay, so that was all which was seen. And then additionally, apart from the vertebral fracture was their primary endpoint, but they also looked at other osteoporotic fractures, and any fracture, overall fracture reduction was 28 to 30% on women with zoledronate, and major osteoporotic fracture, generally they are hip fractures, they're reduced by 40%. So Dr. Soumita, what's your initial take on these results? Do you find this interesting?
That seems very interesting, and that probably indicates that though the patients had a mild osteopenia or almost normal BMD, they had some kind of fracture risk burden to start with. Probably that is why they did benefit from this treatment, and the risk reduction is quite impressive. If we look at the interval and the number of injections compared to that, risk reduction is quite impressive.
Very, very true, very true. Right. So this is a very simple thing to do, right? You just take women with 50, above age of 50 instead of taking 65. So you take that 50-year women, do a BMD, right? Just recognize whether they're having osteopenia. If they're having osteoporosis, naturally you're going to treat them. But if they're having osteopenia, give them 1 dose of zoledronate, and then every 5 years you treat them. It's very simple to do, not complicated at all, right? So which is again makes it quite attractive because it's very simple. So overall, there was statistical significant thing. What do you think about the number needed to treat, Dr. Soumita? Is that an impressive number? It's a good, reasonably good number. What's your take on the NNT? Dr. Soumita? Yeah, I think screen is stuck. Okay, so let me then Dr. Soumita, can you hear me? Yeah.
Am I audible?
Yeah, I think your voice was not audible earlier. Now we can hear you. Little broken, but we can hear you.
Yeah, I can hear you clearly. Am I audible?
Yeah, now you're audible.
Okay,
Clear.
okay. Then I'll change my. Okay. So, what I feel is number needed to treat of 21 literally means that we need to treat 21 postmenopausal women with such BMD for 10 years with 2 zoledronic acids to prevent one fracture. right? This
Correct.
is the literally mean.
Hmm.
Okay. So I feel if we can do injections that to over 10 years and 5 years apart, and with such fracture risk reduction is quite impressive. And
Hmm.
NNT of 21 becomes a little uh, favorable for me. To me, at least, it's favorable. So,
Right.
and if you consider the cost of the injection also, I feel zoledronic acid is quite cheaper. It's easily available. It comes around at 1500 rupees. That is even lesser than 1 month of hormone replacement therapy, which the woman
Right.
has to take for years, right? So
Right.
two injections doesn't matter, I feel, and potential side effects, yes, side effects are there, but that is not more increase for patients who are osteopenic compared to those who are having osteoporosis. The risk or the
Right.
potential side effects are similar for both the groups. We are giving injection in an osteoporotic female. Why can't we give? So risk is not the issue here. So
Hmm.
it seems favorable for me.
Right. Okay. So absolutely. So I think it's a and Dr. Soumita, I also feel that this the other part, the
Am I
major
audible?
osteoporosis. Yeah, yeah. The major osteoporotic risk fracture reduction by 40% is also quite impressive because that's these are the women who a major osteoporotic fracture could be potentially dangerous as well, could be even life threatening, right? So even that number is something interesting. So Dr. Somita, let me put you let me say, in your practice, would you then based on these paper change your practice to what you're doing right now? Would you screen these women? These women might come for some other reason to your clinic. Would you insist that they should be screened for osteoporosis and then follow this similar approach?
Yes, I feel the women who are having very menopause in the recent years, and
Hmm.
those who are concerned about their bone health, number one.
Correct.
Number two, those who are not very suitable candidate for HRT.
Hmm.
HRT has
Correct.
many contraindications. So
Right.
those who are having family history of breast cancer or
Hmm.
endometrial cancer, or those who have a high risk of venous thromboembolism, where we cannot put them on HRT. In
Correct.
these cases also we can go for such treatments to reduce
Hmm.
the fracture risk reduction. Of course, I would like to do a fracs to start with, because
Right.
here I feel they did not do fracs in the baseline,
Yeah.
because so we do not know what was their baseline risk of fracture. So
Right.
that is the thing I would want to look at.
Okay, that's a good point. So maybe adding a frax to the layer could be interesting and could be a good determinant to, again, see whether to treat these some particular women here versus not treat certain. So I think, in fact, their NNT would have improved if they probably use frax as an additional tool for, considering treatment. But of course, this is a long prospective study. So I think, they started with an idea and they followed that up over a period of time. Maybe some differences here in terms of maybe a retrospective analysis of the data could, with adding of fracs, could give us some more flushing out of who are the women who are better candidates in this case. Okay, to the audience, we'd love to have your questions. So just if you have a question, put it up in the Q&A section, and then we'll take it up during the discussion as well. So overall, I feel this could be potentially practice changing. We could probably look at younger women as at least as a proof of concept. It's a great idea that probably we are looking at, and as Dr. Soumita very rightly said, a very important point she said that some of these women, remember, they are having osteopenia. So some of these women, and they still had a fracture, right? So we are probably BMD is often not enough for screening this women. We are definitely missing out women who are potentially fracturing despite having an osteopenia and not having osteoporosis. So I think that's a great point to really take home and think about it. So I think, again, as a proof of concept also, it's a very interesting idea. And I think that's something which we should be probably looking forward for more data on this particular group of women, right? So that's the whole idea. So moving on, Dr. Soumita, you want to add anything to this paper? Shall we move on to the next one?
We can
Yeah.
move,
We
right?
can, right? Okay. So let's then move to a second paper, which is again a very interesting idea. And in fact, this is a paper which I read it and then I had to kind of dig in through some more data on this and some interesting, very completely novel and interesting idea. And then I looked at some of the other papers, and there were approaches done for other conditions with this. So let me then first tell you the problem, and then we'll go to the paper and what kind of solution they found out, right? So what happens is that whether you're doing a parathyroid surgery or whether you're doing thyroid surgery for some other reason. For example, let's say you have a thyroid cancer and you're operating that women, or you have a head and neck operating such patients, or if you have a head and neck cancer and you want to do more extensive resection, oftentimes, what happens is that the surgeon often knocks off the parathyroid gland, right? So they can sometimes, inadvertently remove the parathyroid gland, which can of course lead to post operative hypoparathyroidism, right, which is again a very important side effect of any thyroid surgery. So whether you are doing a parathyroid surgery per se, or whether you are doing a thyroid surgery with a goiter or a nodule or a malignancy, right, in such cases you could potentially damage a parathyroid gland, and that could lead to problem, right? So there could be an accidental removal of parathyroid. Now, as a standard approach, what surgeons typically do is that if they find a tissue which is potentially could be a parathyroid tissue, they often send it for frozen section, and again wait for the report to really show up to whether that was a parathyroid gland which was accidentally removed. In certain cases, our own surgeon often does that. He can actually re-implant the parathyroid gland into the sternocleidomastoid, or sometimes even in the forearm, right? So that's so that at least some tissue is remaining, and that could be even something. It takes up the blood supply and can be a functional tissue. But then for that, they need to know for sure whether what they've removed was actually parathyroid, right? So that's often a process, and that's why they often wait for the frozen section analysis to really show up. So it's a common issue in any of these head and neck or thyroid surgeries or parathyroid surgeries. So it's a common challenge which we often face. Now, as of now, frozen section is a gold standard, but it's more labor intensive and slow process, because again, you have to have the pathologist on standby, and they wait for the for the report to kind of generate it. Sometimes there are surgeons who are more experienced, often have visual identification. They'll often identify that no, this tissue was parathyroid. So that would of course depend on the surgeon's experience. There is another technique called autofluorescence, which requires specialized equipment, which may not be universally available, so it is more expensive. And you could do intra-PTH, which is again a standard practice when you're doing a parathyroid surgery, but may not be a standard practice when you're doing a thyroid surgery, and you have inadvertent removal of parathyroid of PTH assay of parathyroid gland. So, Dr. Soumita, what's the usual practice? I understand the practices may be different in different parts of the country, in different centers. In your center, what is the thing which your surgeons typically follow in their in their respective process?
Yes, actually, we are working in the government setup, and this is, still I would say a resource poor setting. So
Yes.
we'd have to rely on surgeons' expertise, because they
Right.
actually do the frozen section very few times, not very
Okay.
frequently, and because it's
Okay.
not always available also. So
Right. Correct.
even frozen section is also not available. So we have to rely on totally on surgeons' expertise from the macroscopic evidence. If they can feel it parathyroid, then it's parathyroid. So this is quite subjective, what
Yes.
we are now dealing with. Yeah.
Correct, correct, absolutely. So again, in our hospital, it also what we have observed is it also depends on the surgeon, right? So there are certain surgeons who are we have a senior surgeon who is very particular about this. He often would check whether you are specifically the tissue which is removed is parathyroid. In fact, I still remember he did a very extensive surgery of a lady where he was so sure that he had removed all the four parathyroid glands that immediately came out of this surgery of the OT, and then called me up saying that, oh, this is a patient who's going to come. I don't think I've preserved any parathyroid, so this patient is going to be your problem now. So and this patient had very severe. She had a very severe tetany. She's still on follow up for many years. Well, of course, she developed. It was a total parathyroidectomy, to be precise. There's nothing much. She had a very extensive disease, so nothing much could be preserved. But again, whatever, if you could identify a parathyroid tissue and maybe reimplant, that does work, right? So again, surgeon to surgeon, things may differ, right? So this one paper where they looked at a novel approach, and they looked at an alternative way of an intraoperative test which could be faster, with a rapid turnaround, which could probably use a point of care device also, which could have high accuracy. It could be inexpensive, and it requires minimal tissue handling. Because remember, if you do identify a parathyroid tissue, we would like to reimplant, right? Rather than just send it as a curiosity of what this tissue was. So that is the process, right? Now, so that's this paper, which looked at a very interesting and novel idea. So what they did was they took a very interesting test. They took an ACTA, EST LDH ratio of the parathyroid. So let me then tell you what this basic idea is, and then what they did in this study. So basically, what the reality is that the parathyroid tissue has a unique enzyme composition compared to all the structures nearby. So whether it's a thyroid tissue or whether it's a lymph node, parathyroid tissue does have a unique enzymatic composition. So the parathyroid tissue, and this has been published earlier, has high AST values, so high AST levels, and relative to the LDH level. That's probably because of the changes in its molecular oxygen consumption and its mitochondrial tissue amount. And we all know that parathyroid tissue is different from it has a different embryonic origin also. And it has been well known that AST LDH ratio more than 1.5 suggests that this tissue is probably a parathyroid tissue. This has been published earlier. In fact, similar approaches have been followed when you are removing necrotic tissue from pancreas. So I apparently looked at more data, and such approaches have been used for pancreatectomies also in the past as well. But this is a study by Bhatt et al., which was published in Indian Journal of Endocrinology and Metabolism. So what they did was they took 35 surgeries, and they took this tissue which they found, and they did a tissue suspension, and they measured the AST LDH ratio in that suspension. And then they compared it with the gold standard, which was frozen section diagnosis. Now, Dr. Soumita, have you come across any such procedure? For me, it's for the first time I'm looking at such a unique
Yes,
approach.
it's a unique procedure. I
Right?
really wonder how did they come up with such idea that
Yes.
they will take out a such tiny level of tissue and they make a
Yes.
suspension, and then they do it for AST and LDH ratio. Though the physiology lies there, as you correctly
Hmm.
mentioned, that it is rich in mitochondrial content, so it will have a high
Correct.
AST content compared to the surrounding tissues, number one.
Hmm.
And also it relies on glycolysis, so for
Hmm.
metabolism, so it is converted to LDH more after glycolysis. So
Correct.
that's the idea or physiology behind that. So
Correct.
it's really commendable.
Yeah, very interesting paper. Though a small sample size, but that was something as an idea, proof of concept is a great idea. So this is what exactly they did in terms of the procedure. So they took the whatever tissue. So they're looking at, let's say there's a suspicious tissue. They took that tissue, whether it's a thyroid, parathyroid, lymph node, and they did a 1:10 tissue suspension in saline. And then they use a point of care analyzer. So why point of care analyzer? Because it could give you results faster, right? So they took a point of care analyzer, they measured the AST and LDH values in this POC analyzer, and they calculated the ratio. And typically the whole procedure took less than 5 minutes, right? And they then compared everything with frozen section to be sure that the endpoint which is there, right? So this is what they found, and this is again, and they took that this ratio of 1.5, actually, Dr. Soumita, has been published before. So that's what I also went through the some of the papers which they have cited, because it's an interesting concept for me. And like I said, then going into the rabbit hole, I found that similar approaches have been done for pancreas surgeries for a long time, right? So this is again very interesting. So what they found was they found actually 100% sensitivity and identifying the parathyroid tissue, which is great, right? Because that's what you want. The specificity was also very high, right? So it was 94.7 for compare when you compare it with as a from to thyroid, and 100% when they compared it with lymph node, right? So that then you're sure that this is not lymph node for sure. This is not thyroid for sure. And the ratio which they took was 1.5, in more than 1.5. The thyroid and lymph nodes typically had ratio of less than 1. So because it has again a different composition. And typically the entire process took a turnaround time of about 3 to 5 minutes compared to a frozen section, which takes about 20 to 30 minutes. It can be done with just have a point of care device in the operating room, very easy to perform, and can easily be done with a routine chemical analyzer also, does not require any specific equipment, right? So Dr. Soumita, any views on this kind of the results which they got? Anything?
Yeah, result is quite impressive in terms of sensitivity and specificity.
Yeah.
Because what I could see that the specificity against lymph nodes is almost 100%. So whenever
Yes.
we are testing any tissue and it
Mhm.
comes like a parathyroid, so we are almost sure this is not a lymph node. Okay,
Correct.
that's we are sure, 100% sure.
Correct.
So that would lead us certain decision making steps in the follow in the correct surgical workflow, because because sometimes we inadvertently take out lymph nodes, sometimes fat, or sometimes the parathyroid tissue. But if it is the only parathyroid tissue, which has to be auto transplanted, not the other. So we don't have to go for the transplantation of lymph nodes, which can be a pathologically malignant or something affected by other disease. So this is going to be very helpful to differentiate it from lymph nodes specifically.
Very true. Very true. So I think great point. And like you very rightly said, you want to, even if you do an extensive surgery, you definitely want to have functional parathyroid tissue, because that often, as we have seen in a practice, that it often impacts the quality of life of the patient later on, right? I mean, the thyroid malignancy has been treated, right? The whatever thyroid disease or any other thing was treated, but the patient then grapples with a post-operative hypoparathyroidism,
Hypopar, yeah.
which could be very devastating for the quality of life of the patient, right? So I think that is something which could take. So this small proof of concept, just 35 patients, but it could potentially change a surgical workflow. In fact, this is a paper which I intend to send to our surgeons as well, and to see whether this could be potentially something which we could study further and maybe have it as a part of our practice. You could then reduce inadvertent parathyroid excision rates. You could then probably look at maybe some other unusual pathologies. Maybe this could kind of open up ideas for other processes as well. And of course, kind of more data in terms of comparison with larger validation, with comparison with frozen section, this will be useful. And again, could also be very helpful. Like Dr. Soumita said, a lot of times we are in resource limited setting, we are actually dependent on the surgeon's expertise and surgeon's visual experience, rather than any kind of data. So it could also be helpful in a limited resource setting, like a lot of government hospitals as well. Dr. Samita, you see this being used or potentially used in limited resource settings? Am I audible,
Sorry,
Dr. Samita?
couldn't get you
Yeah.
properly. Can you?
Sorry. Yeah. So I said,
I don't voice.
Yeah, no problem. Do you see this being used in limited resource practice settings?
So this could be an option for in limited resources if we have to. But what the price they have quoted is around 15 lakhs. So the government, once they can procure such a point of care machine in the operating room, I feel so. So in those cases, we can go for procurement of such instrument and do this in the operating, get the most out of it.
Right. So yes, it does have a lot of advantage again in terms of time, and in terms of whether it will be cost advantage or not. Probably would be something which needs to be looked at further. But definitely has kind of more precision in terms of time. It has some advantage as well. Yes. So shall we move on, Dr. Samita? You to add anything before we move on to the?
Yeah.
Oh, okay. So let's move to the study number 3.
Definitely.
Yes, and this one, Dr. Soumita, she told me actually she has, she had actually been a judge in this on this particular paper, which was actually submitted in one of the ESI meetings, and this is about gonadotropin therapy for male infertility. Now, let me tell you the background. So, this is about treatment of hypogonadotrophic hypogonadism. Right now, in hypogonadism, in fact, this is an area where a lot of controversies has been there in terms of what could be the right approach in terms of treatment. Now, I still remember when I was back in the day when I was actually a resident in endocrinology. That time, most it was the standard of care was still testosterone injections, and which was being at that point of time being challenged by the fact that why not give HCG and HMG, which could be potential, that's
Even we
beta.
are still using testosterone
You're
because
still
the
using
patient, most
testosterone,
of
right?
the patients cannot afford HCG.
Afford. Correct,
Yeah.
right? So that is, that's a constant challenge right now within the use of HCG and HMG. A lot of things have changed, right? So there are different approaches to the therapy. In fact, let me just to tell you, there is one school of thought which says that you give HCG alone, so you start only with HCG first, and then later on add HMG. There's one school of thought because they say that there could be intratesticular testosterone increases with HCG, and that alone could be enough for spermatogenesis. There's another school of thought that says you give HCG plus HMG right at the beginning, right? There is one another concept is that these people with these men with these rather children rather in a sense with hypogonadism have never gone through mini puberty. And in mini puberty, you have mainly a predominance of FSH, which is basically represented by either HMG or a recombinant FSH. So since these children have not gone through mini puberty, you mimic the real life natural system where you first give them just FSH in terms of as to simulate mini puberty, and after that you add HCG with FSH. So that's another school of thought as well. So I think there are a lot of approaches to it, and this is one paper which actually tried to clarify as in terms of doing a actual clinical study to compare two approaches. Right now, they have not compared all the approaches, but these are two approaches which are actually quite popular. So that is what they have tried to compare. So they took men with hypogonadism established, and the idea was to basically look at not in terms of anything else, but rather in terms of spermatogenesis, because again that is what impacts the long-term fertility, and that down the line that is what often kind of differs in terms of the overall outcome, right? So they took the debate really is to first give either you start these children on HCG and HMG or HCG and recombinant FSH directly, or you give FSH first and after that you switch that on. So that's the usual comparison. So like I said, these are the two treatment comparisons. So you give HCG monotherapy and then FSH if needed. You combine HCG and FSH, right? And these are the common sort of ideas, right? Okay, so Dr. Soumita, again for our audience, again, can you explain a little bit about the mini puberty and why all these approaches, why they differ and what is the need for these things?
Yes. So the idea behind, as you mentioned, that we are trying to simulate the mini puberty here, because the patients who are congenitally hypogonadotropic hypogonadism, they do not
Correct.
have the GnRH or the gonadotropins, which is actually raised in the first few months in a male. Like in the first 3 or 4 months, we get to see a rise in the FSH, LH, and inhibin B, and that is clinically manifested by increase in the testicular volume, increase in the rugosity, scrotal rugosity, increase in the penile length. These are all clinical manifestations of mini puberty. But these children do not experience that mini puberty because of their congenital defect. Now, the idea of treating these patients with FSH is we are trying to create a hormonal milieu that will simulate the mini puberty. That means that we will give FSH, pulsatile FSH, and that will increase the Sertoli cells, help in growth and maturation of the Sertoli cells, which would ultimately lead to the induction of spermatogenesis. This is the whole idea behind this FSH injection. Now, if we can give FSH first, then we go for ACG or ACG, or we can go for a simultaneous approach as they have used in the this particular study. So let's see what did they find in the next slide.
Yes. Absolutely. So, very rightly said. So this is what they did, right? So they did a comparison. They took Group A and Group B. So Group A, again, small numbers. Remember, these are very small. We generally in practice also in research also we find very small numbers really to take. They took 23 azoospermic men between ages of 70 to 40 with hypogonadism, and they took 12 of them were given upfront HCG plus FSH. And 11 of them were first given FSH for 3 months, and then HCG was added, right? So that's the second approach which was followed, right? Now, the second approach is actually more expensive and cumbersome. The other problem with the second approach is that, yes, it does simulate a mini puberty situation, but you are actually denying these men the advantages or the benefits of the virilization and androgenization which would happen with giving HCG. So sometimes patients also lose interest in the treatment because they don't see any changes for the first 3 months, because they're just going to have maybe increase in testicular volume, but apart from that, they will not experience the androgenization which they are actually coming for to the doctor, right? So that's often also one of the challenges. In fact, this is what we face in clinical practice. In fact, when we saw one of some papers about this initially, we started giving HMG and FSH initially, and we would also we'd have often a lot of dropouts in treatment also because of the fact that they did not see any benefits, and they followed up these men for 18 months, and they looked at until spermatogenesis, and they wanted to see time to initiation of spermatogenesis. So this is a paper which was published in Indian Journal of Endocrinology and Metabolism, and as Dr. Soumita said, when this paper was presented, she was actually one of the judges in that. So Dr. Soumita, overall, the design of the study, and what do you feel about this? And I think it's a well conducted, well thought of study also, because
A
they've thought of a lot
fantastic
of.
study from
Yeah.
practical point of view. It's a very
Yes.
fantastic, excellent study, I feel,
Mm.
because this is the category of patients we get to treat day in and day out, and we still feel that we are not doing justice to the patient by giving testosterone, because
Right.
external testosterone or HCG, to some extent,
Mm.
one school of thought
Mm.
is there that HCG alone can be detrimental from the germ cell as well.
Mm.
So this particular study, where we could see that HCG and FSH combination treatment is actually better than the FSH treatment alone. So that reassures us about, again, the role of HCG in this particular group of patients.
Absolutely. Right. And to the audience, all these papers, all the full text papers, this is actually IJEM paper, which is full text is easily available, but we have put the full text also in technochronology.com, so you can have a look. Now, to kind of get into nuance aspects of the actual treatment, they give HCG 2000 international unit twice a week, with FSH 150 international unit 3 times a week in group A, which was given both. And the group B was initially given FSH 150 internationally 3 times a week for 3 months, and then they added HCG twice weekly. So that is how they typically did. Now they titrated the dose to achieve an FSH target of 4 to 8, which is something which we did not used to do earlier. In fact, that is something we also started doing recently in terms of monitoring the FSH value. We also only used to monitor the clinical signs and the
And
testosterone
testosterone.
testosterone value, right? So this is again something which is interesting. And they titrated the HCG dose to target a testosterone value of more than 259 nanogram per deciliter, right? So that is what they did. They followed up these men with monitoring the testosterone, FSH, LH, inhibin B, and AMH values every 3 months. They looked at the testicular volume, and they looked at the semen analysis, right? So that was the overall idea. Dr. Soumita, again, what's your practice? Again, let me then ask you this. You said, of course, limited resource settings. We are also very keen on just starting testosterone because that is what patients can afford. But again, given a choice that there is no inhibition to cost, what would be your ideal approach before, of course,
We were still
yeah.
following the current recommendations that to start with ACG for first 6 months. If the patients already develop spermatogenesis or sperm, then probably we don't have to go for the HMG or FSH. If the patient doesn't respond with first 6 months of therapy with ACG alone, then we would add FSH to it. That was our current practice, those who are seeking fertility.
Correct, absolutely. Right. And again, to add to what Dr. Soumita also said, one of the challenges actually is the cost, right? Because
Yeah,
FSH, if I recombinant FSH
FSH
is much,
is, yeah,
much,
expensive.
much, much expensive. Even HMG is more expensive also, right? So HMG is also expensive. So I think that is one of the challenge. In fact, 150 internationally 3 times a week is quite expensive. Again, just for the audience who are not dealing with this kind of patients every day, uh, generally, these are available for intramuscular injections, but we use it off-label as subcutaneous injections, just like you take insulin. In fact, we teach the patients how to extract this and give it subcutaneously, though the manufacturer recommendation is still intramuscular, right? So do you do that, Dr. Soumita, or do you also give
We actually go for intramuscular only.
intravascular, right? So the advantage of giving subcutaneous is actually that patient can self-administer, because otherwise it's very difficult for the patient to take injections this frequently unless
Yes,
they
yes,
have
yes.
something. So that's
Yes,
so
definitely.
so So these are some of the challenges in terms of
Practical tips. Yeah.
practical challenges which you learn through the thing. And I think so let's see the results. And it's again a very interesting study with interesting when I saw this headline I said, okay, just tell me the results first, because I'm really interested in knowing. So group A, which was again just to kind of reaffirm, the group A was where they gave HCG with FSH together, right? So they actually had 100% success rate in terms of spermatogenesis. Group B with the FSH pre-treatment actually had 81% spermatogenesis, and the time required for spermatogenesis was about 10 months with the first group A, whereas 15 months with group B. And there was actually this was statistically significant. In fact, the group A achieved a greater sperm count compared to group B. Right. Again, of course, the sperm count had no statistical difference. Dr. Soumita, are you surprised with these results upfront?
No, not really. I
Yeah.
expected the results would be similar, but
Right.
yes, the ACG and FSH had a significant earlier induction time for spermatogenesis compared to the FSH alone. So that is quite impressive.
It's quite
Otherwise,
interesting.
the results would be similar. I expected the results would be probably similar.
Correct. Right. And so yeah, I think then this mini puberty hypothesis probably is challenged, right? Do you yeah?
Definitely,
That is it, right?
yeah.
So I think that's where now you have one evidence to say that probably this was not the right idea of giving FSH first. And I think we would then probably consider the more kind of conventional approach which we used to follow anyways, is to give HCG and FSH right at front, and then kind of work it from there. Does this, Dr. Soumita, probably reinforce your practice, or make you think about your practice or change your practice?
Yeah,
Is it?
definitely. Because as I said, we had a somewhat little bit hesitation about ACG. Are
Correct.
we doing
Right.
any harm to the patient?
Mm-hmm.
And this span, the faster time to spermatogenesis also convinces us to use it, because the patients are what the patients want at the end of the day is the fertility.
Correct.
So this is the objective evidence. We could show them that this is with the combination treatment. But the only challenge is more number of pricks. The
Correct.
patient has to be counseled against that. But again, we'll have to give them the choice that one is more number of pricks versus faster spermatogenesis. Other is probably less number of pricks. But the cost, I feel, in the long term is going to be equivalent for both the arms, or even lesser in the combination arm.
Very true, Dr. Smita. Yes. So very nicely put. And you said you are the judge in this. What did you find really impressive about this paper? What were the merits of this? This is, yeah, I mean, the approach and the entire thing,
Yeah,
again, it's
first
an
of
Indian
all,
study,
the
Indian
idea
study.
was
So
quite unique. The design
yes,
of the study was quite unique to look
yes,
at such a practical thing which you never thought of. That
correct.
to come up with the concept of this was really encouraging for us. Number one. Number two, the results were quite impressive. The testicular volume increased from 2 ml to 8 ml. That was quite impressive enlargement of the testicles. And of course, the time to spermatogenesis, where we can say that instead of waiting for a longer period, when one can have the spermatogenesis faster. So these are the points which actually were favoring this study.
Very true. Right. So again, great points. And it's good potentially impact. At least for me, it
Yes, it's a
reinforced.
practice changing sort of thing.
Yes, absolutely. Right. So this is something very, very useful to us. And let's take the last paper, Dr. Soumita. And this is again this is a more global thing. This is again will be useful for practicing physicians also, because this is something which a lot of clinicians face this as a problem. So we often see in practice, we of course very well know what is subclinical hypothyroidism. That is when you have the TSH which is high, but the the T3 T4 are normal, especially free T4 which is normal. But in certain periods of time we see TSH values which are very high, and yet the T4 typically is normal, right? So we'll often see values of 30s and 40s of TSH, and the T4 is often normal, right? Which again typically we used to be taught, and Dr. Soumita would probably reinforce that, if you have if a TSH of more than 20, you will really expect the free T4 to start falling, right? Which sometimes you don't.
Yes,
So,
yes, yes,
is
yes.
this the rule of thumb? This is what we were taught. Is
No,
this
no,
what
no.
we?
That's what I was wondering when going through
Yeah.
this particular paper. We really do not have such cutoff when, with the
Hmm.
rising TSH, the FT4
Hmm.
level, or the T3 level for that matter, starts to fall. So this
Hmm.
is where we get stuck whenever we are
Hmm.
interpreting such results. If
Correct.
we could
Correct.
say that yes, if the TSH is 30 means the FT4 would definitely be low, then it
Hmm.
would be easier for us. But there is
Correct.
no such data or
There is no
such
correct.
evidence.
Absolutely, right. So again, that is where the question really asked is that, are we treating the right patients, right? So that's the often the problem, right? So of course, if you in a broad sense, if you see what could be the reasons for that, right? Now we have one very similar issue, which is what we know as macroprolactin, right? Dr. Samita, can you tell us more about macroprolactin? Is
Yeah,
again something which again these are things which are drilled to endocrinologists' brains by the time they come out, right? So, yeah.
Yeah, macroprolactin is a thing that when the prolactin forms a complex with the immunoglobulins in the circulation,
Correct.
and that comes into the detection, and we get
Correct.
to see a falsely elevated prolactin level.
Correct.
So
Correct.
whenever the patient is still asymptomatic and the
Mm.
prolactin is incidentally detected to be falsely high, that is called
Mm.
probably due to macroprolactinemia if
Correct.
other causes of hyperprolactinemia is reasonably ruled out.
Correct. Absolutely
So
right. So
macroprolactin, yeah.
yes, please go ahead, please.
Okay. So macroprolactin, how we exclude this macroprolactinemia is by doing a PEG precipitation. If the
Yes.
recovery after a PEG precipitation method is more than 60%, then it is biologically active prolactin. If it is if the recovery is less than 60%, that means it's probably due to the macroprolactin.
Absolutely. Right. So again, broadly, and let's put that in the context of TSH, uh, you know, uh, the differential diagnosis. So again, we are talking about people who are having TSH of more than 10, but free T4 is normal, right? So one is, it could be obviously true subclinical hypothyroidism, which is, what is the most likely and what we are expecting, right? Uh, but it could be a condition which is known as a macro TSH, right? Just like your macroprolactin. So you have the TSH, which is bound to an immunoglobulin, and because of that, its half-life in the circulation also becomes high, and they get detected into the system. So that's not true biologically active TSH, but that's rather which is something which is bound to an immunoglobulin. Hence it has a kind of a gets detected into the system. There could be heterophile antibodies. And Dr. Samita, what are these heterophile antibodies? Again, we
Yeah,
hear a lot about
profile
this.
antibodies in the general populations, they carry a certain percentage of population. They carry heterophile antibodies, or for that matter, HAMA, anti-human, anti-mouse antibodies. One of the kind of this heterophile antibodies in their circulation. What
Hmm.
they do is they get sandwiched in between the capture
Hmm.
antibody and the detection antibody during a TSH assay. So they
Right.
replace the TSH and they get sandwiched between the capture antibody and the detection antibody, which gives us a falsely raised TSH result. The
Correct.
TSH might be normal in that particular patient, but what we get in the result, in I mean biochemical result, that is a raised TSH, falsely elevated TSH.
Absolutely. Right. So and this is a condition, if Dr. Deep Datta, also from IPG1, had coined a term called laboma. I still remember he was a few years senior to me, and I remember reading his paper on this. So this is a condition which we call it as a laboma, right? Which is actually not a
Yeah,
true condition, but it's a lab
yeah.
anomaly,
Mm,
right? So macro TSH and heterophile antibodies. These are two very important common differential diagnosis, where you often see patients who are not having true subclinical hypothyroidism, but rather having a lab abnormality, which often leads to the false TSH high values, right? There could be rare conditions like a TSH secreting adenoma, which we are very, very rare. I think we probably see in your whole career, just a few cases, and a thyroid hormone resistance syndromes, again, very rare. So essentially, we are
yes.
dealing with the three top ones, right? So that is true subclinical hypothyroid, a macro TSH, or a heterophile antibodies. How often do you really suspect the other two? Because most of the time we are in a busy OPD, we'll rather give them a levothyroxine and forget about it, right? So how
Yes,
do
yes.
we? Yes, yeah.
Yes, the first thing that strikes into our mind is the FT4 or the total T3 level is normal, and the
Correct.
patient essentially does not complain of any symptoms. That too should raise our suspicion. If we can
Correct.
find that the TSH level is in to the tune of 40 or 50, and the FT4 level is absolutely normal, the patient is
Correct.
not having any, that should raise our suspicion. Then probably this is a lab error. So we should at least repeat this test to reconfirm if it is true. If the test comes again comes with similar results, then probably we should go for ruling out this macro TSH or heterophile antibodies. So
Absolutely.
we
Yeah.
have dilution methods to exclude these heterophile antibodies after
Correct.
serial dilution. If we get still a TSH in the normal, we get TSH in the normal range, that rules out our heterophile antibodies. If the TSH is still high, probably we should
Correct.
think of macro TSH.
Absolutely right. So and another trick which we also do is we often change the kit also, because sometimes we have heterophile antibodies specific to
Yes.
a certain monoclonal mouse, because remember these are all mouse antibodies, and that's the reason why, because these assays are made with that. So when you change the kit also, they could have a different that binding could change, and that is another way of how we so simplest test is often, like you said, repeat the test. So that's the
Do
first
it
thing
from a
which
different lab or
we
different
from a
machine.
different
Yeah.
lab with a different machine, right? So that's the thing. Obviously, it's important that we don't treat this patient wrongly. So this is what they did. So this is a very interesting paper. They actually this was published in Indian Journal of Endocrinology and Metabolism very recently. They wanted to see how common is actually macro TSH. That is what they wanted to see, and actually then to help us clinicians really be cognizant of this fact. So they took 1,500 patients with and did thyroid function test in them. 135 had subclinical hypothyroid with TSH more than 10 with normal free T4, and all of them, they underwent serial dilution and PEG precipitation. So that they did a PEG precipitation to basically see whether the patient is actually having true elevated TSH or a macro TSH, right? So I'll quickly go to the process. They took all these patients, 135, so almost 1/10 of the total group had a subclinical hypothyroidism, which is again very similar to the prevalence that we have in our society. And then they did serial dilution to rule out heterophile antibody interference, as Dr. Soumita very rightly said. And for macro TSH, they did a PEG precipitation, right? So they were PEG precipitation to remove the macro TSH. It's very similar to what we do in prolactin also, right? And their definition, what they did, was again similar to what they do in prolactin, is that the post-PEG TSH, if it was less than 60%, they labeled that as a macro TSH. And if it was more than 75%, they labeled it as a true subclinical hypothyroidism. Of course, they also looked, like Dr. Soumita said, at the clinical symptoms of the patient, thyroid antibodies, maybe ultrasound if needed, wherever, and rare cases of TSH producing adenoma, we probably would run a MRI also. But the broad idea was to see what is the prevalence of macro TSH in a general population. That was the whole idea. Dr. Soumita, do you find this again an interesting study, and do you kind of the methodology? Do you agree with this, what they've done so far?
Yes, because in the BG OPD schedule, it often goes out of our mind that macro TSH could be actually a factor whenever we are interpreting such results. We think of etrahama, we think of heterophile antibodies, we think of subclinical hypothyroidism, even TSH, OMA, TSH secreting adenoma, a very rare thing. But macro TSH is something which often goes out of our mind. So this again, and again, it's a food for thought, I feel. We will have to look at the TSH level. We'll have to look at the patient's symptomatology, whether the patient is having autoantibody against autoantibody or not, like anti-TPO antibody. Or if we have to repeat the TSH, if we get a very high level of TSH with reasonably a normal FT4 level, and if it is stable over a period of time, there is no such change of TSH over a significant period of time, then probably we'll have to think about macro TSH, and we'll have to ask for a precipitation.
Yes, very true. So I think, again, let's look at what they found in the terms of results, and it was very interesting. They actually found good prevalence. So, in fact, 11% prevalence of macro TSH, which is not small, right? And again, overall, if you see from the original population that was screened, it was 1%, which is fine, right? But and they found 0.36% of heterophile antibodies. So, Dr. Soumita, we worry about heterophile antibody, but on the contrary, macro TSH is far more common than heterophile antibody.
Yeah, that's what I was trying to get.
Very, very interesting finding, right? And very interestingly, and then I read through the paper also, the mean TSH in these patients who are actually macro TSH was at almost 61, right? So far, far higher value. So typically, if you see
Yes.
very high TSH, in fact, any endocrinologist or physician would have treated this patient, and
Yeah.
so right. So that was the thing, and a lot of them actually did not have hypothyroid symptoms at all, right? Only 13% actually had symptoms, and it was again just like other autoimmune conditions. It's more common in female compared to male, but that is what they eventually found, right? So surprising studies, and does this kind of become an eye opener, Dr. Samita, for you?
Yes, definitely. And
Right.
it also makes us aware of the fact that we are probably mistreating the patients, almost
Yes.
11% of the subclinical hypothyroidism.
Hmm.
So we'll have to be aware, even if we are sitting in a busy OPD schedule, we have to be aware that macro TSH could be a possibility. So wherever the TSH is high, we'll have to be
Hmm.
cautious whenever we are interpreting such results.
Absolutely right. So I think it's a great lesson, I would say.
Yeah,
And so I think it's for me, it's definitely an eye opener that the prevalence is actually quite high compared to what we used to assume. We used to, like Dr. Soumita said, in our practice also we used to worry about HAMA, heterophile antibodies, but actually the prevalence in this study was of macro TSH was far more common. And I think probably we should, wherever the clinical symptoms do not match the lab results, we should definitely consider probably retesting one, and if again the results kind of match, then probably consider asking the lab to do a check for PEG precipitation with a macro TSH. So I think that is something which Dr. Somita very rightly said. Anything you want to add, Dr. Somita, to this particular paper?
nothing.
Okay, great. Thank you. So I think that is, let me then summarize. And Dr. Somita, thank you so much for sticking with us. We have almost crossed an hour, but it was really fun discussing these things with you. Let
Yeah.
me then summarize some of the papers. I think potentially practice changing as well. We talked about the
Yes.
first paper, which was fracture prevention, where probably we need to look at younger women. Need to probably consider osteopenic patients also could be potential treatment thing. Then we looked at a very innovative paper where they took patients with, and again from India, they took patients where they suspected a parasite tissue. They actually measured with a point of care device at AST LDH ratio. And if it's more than 1.5, they actually concluded this was a parasite tissue compared, and it was very strongly correlated with the frozen section values. Then there was this very interesting paper which actually again reinforces, maybe helps aids our practice. They took men with hypogonadotrophic hypogonadism, uh, especially looking at spermatogenesis, and they compared pre-treatment with FSH versus a simultaneous treatment with HCG and FSH, which they found that the HCG with FSH treatment was actually much effective compared to the other approach, which was the mini puberty pre-treatment kind of system. And then they looked at macro TSH, and they took about 1,500 patients. Then they screened down to about 150, 130 who had subclinical hypothyroidism by definition, and they found that the prevalence of macro TSH was actually quite high. Almost 10%, 11% of patients actually had macro TSH, which they concluded by PEG precipitation formula. So it's actually it's probably more common that we think in practice, and that's why often again, like Dr. Samita said, even in a busy clinical practice, we need to keep our eyes and ears open and probably suspect these conditions, instead of just blindly treating a lot of these patients. Dr. Samita, anything you would like to add, and anything you
Nothing,
feel that?
nothing. You have covered almost all points, and thanks to you, I got the opportunity to participate in this program, and it was really fun for me, fun learning for me actually. Yeah, and all the substances and all these materials provided you took a lot of efforts to make this. Thanks to you, and I got it was a learning for me. So thanks. It was
Yeah.
really a fun and I thoroughly enjoyed it.
Thank you, Dr. Samita. Thank you so much for this, and thank you being so gracious and being part of this meeting. So this is what we'll end. We'll see if there are any questions from the audience. And again, if you have a question, we don't have much time, so we'll just take a couple of questions if there are quick questions, and then we'll call it the day. Yeah. So we had one question which was Dr. Samita, quite obvious, which was, what's the best treatment for hypogonadotrophic hypogonadism? I didn't take that question then because we were before the results. This question was asked, but a very important question. What's your go-to for treating hypogonadism? again, if cost is not an issue
Yes,
and
as I
patient,
already said, given
yeah.
all the options, if I am to choose, now probably I would go for the combination therapy.
Correct.
Because at the same time we're trying to maturate the Sertoli cells. On the other hand, we are trying to increase the intratesticular testosterone. This is probably the best way to mimic the physiology, I guess, and probably this is the reason they got faster results. So if price is not an issue, if the patient is not very phobic of pricks, then probably I would go for this. And keeping, of course, we'll have to look for the side effects and everything in mind. But given a choice, I would go for this.
Absolutely. Thank you. So I think that's a great answer to that. And we'll, if there are no more questions in the audience, we'll consider calling the day. Thank you once again to Lupin Azadio division, which is the maker of, empagliflozin with linagliptin combination. And I think, again, no editorial content was influenced by, any pharmaceutical company. It was complete editorial freedom, which is, again, fantastic. From Lupin's side, this is the second time we are doing this with Lupin, and we hope to continue this every year because it's a great opportunity to discuss with great minds with Dr. Soumita and discuss some great interesting papers. So again, we'll be joining. Well, we are not having the one on Saturday because unfortunately, our guest faculty had some prior engagements, but we'll be having a next session, very soon, which is on the 25th, I believe, 25th of November. Since you have already signed up, you will get an email. And again, if you missed any parts of it, you'll receive an email with the link to the Technochronology group on YEARMED. We'll be putting this video also on our YouTube channel, Endocrinology India. So if you again want to kind of have a look back, please feel free to do so. Thank you, Dr. Soumita. Thank you for wonderful,
Thank you, Dr.
wonderful session. And Subhas, you want to add anything?
No, sir, it's okay. Thank you so much. Thank you, Dr. Soumita Mandal. Thank you, sir, for such a wonderful session. Really, we enjoyed a lot. We'll continue the same in future also. Thank you. Thank you for the opportunity.
Thank you. Thank you so much. And wish you a good night.
Very good night. Yeah.
Good night. Bye.
Good night.